Thank you, Mark. It's a pleasure to be here with all of you presenting our work that we are doing at the National Cancer Institute together with Kanan Desai and Mark Shipman and all the team on ABE. Kanan will not talk, but she will be available at the discussion if needed. And we had discussions with Murat Gultekin about the use of artificial intelligence in high-income countries, and so he may give some words after my talk. I will concentrate on the work we are doing at NCI. We have recently seen a paper in Lancet Digital Health showing the applications of artificial intelligence and how these applications are being approved by FDA or the European Commission. And you can see here the trend over time increasing dramatically. And if you are able to read this, you will see that the majority of the devices or applications are based on radiology or cardiovascular diseases that use image evaluation. There is only I identify only two applications in obstetrics and gynecology that mainly relate to fertility issues. There is none yet approved for cervical cancer prevention. So how artificial intelligence could, let me take this out, how artificial intelligence could work for cervical cancer prevention? And we have heard here a couple of times today that we are aiming at screening 70% of the women in reproductive ages all over the world to be screened twice in their lifetime with a high accuracy test that generally we refer to an HPV test. If we do that, about 10 to 20% of the women will have a test positive. But if we are in an environment of women living with HIV, like in many of the sub-Saharan Africa countries, we may have even above 50 to 60%, if not 80% of those women will be positive. So to treat all these women, we may lead to an important overtreatment. So we always think carefully about having a triage step. But triage step is not always clear, and in low resource settings we have been using visual inspection after acetic acid application, but now after we have been reviewing all the data at WHO and at IAR with all our collaborators, mainly including as well Mark Arvin, we reached the conclusion that this approach has poor accuracy and has poor reproducibility. And so we need to improve our triage approach that would be as well a low-cost approach. There have been some efforts to include enhanced visual inspection using digital images, but there is still an unclear benefit of only looking at the image. So we think that AI may assist the visual inspection after acetic acid because we have promising results, and we are working on trying to develop this approach. Generally, when we see an image, being a colposcopy image or a VIA image, we'll see the image, larger or smaller, but it's the image that we can see with our eyes. However, the computer sees much more. The computer uses the pixels of the image and combines, if it's a color image, the three colors, red, yellow, red, green, and blue, and it will give a value for the intensity of these three colors and will produce a code for each pixel. So the computer will be seeing a much more detailed analysis of that image, and that is what our hope that our algorithms will be able to have a much better prediction of what we are seeing in an image. So how does it work? an AI model. Generally, we use the example of a neuron and how neurons get an input signal and can produce an output signal that can as well be launched to another neuron. In reality, if we are quite probably many of us familiar with what is a logistic regression, and an AI model will work mathematically similar to a logistic regression approach in which we include several input. Each input will have a given weight, and all these will be cross-tabulated in between, generating many parameters. If in logistic regression we may have 300 or 100 parameters, in artificial intelligence this cross-matching will can reach millions of parameters, and all these will result on then an output that is what we are interested in. If the basic general approach that we are using now is what we call a supervised approach, in which what we are doing is we have a large repository of images, thanks to many of the collaborators, many of whom are in the audience. And what we generate is what we call a ground truth. Ground truth is what I am going to use as a reference for evaluating an image. And we generally use histology to verify any lesion that is CIN2+, CIN2, CIN3, or cancer. And we are going to ask for each image that we have to have this comparable histology. For images that come from women that they had a normal diagnosis or a low grade, sometimes we don't have histology. So if it's the case that we don't have histology, we use the expert review to really confirm that that image corresponds to a person with no lesion visible, no acetowhitening visible, or if there is acetowhitening that clearly it's not a high-grade lesion. So then our model works that we input all the images that we want to evaluate. Having all of them will have this ground truth label, and then the algorithm runs internally, does all the cross check, and tries to match this with our ground truth. Finally, and this is all very simplified, and I have to remind you that I am an epidemiologist, I am not an engineer on artificial intelligence. What we really want, and that's what really we care, is that all this derives in a clinical test. And this clinical test should provide a criteria for management. Are we going to treat the patient, or are we not? We do not need to treat that patient. So another issue that is very important is which device are we going to use. Our initial studies were based on cervigrams that provided excellent quality images, although a bit flattened, but very good quality. Now this is not anymore in the market, it's not produced. So we have possibilities to acquire images from colposcopes, but these are very expensive. We have some examples of mobile colposcopes or digital cameras, designated device that like the pocket colposcope or smartphones. All these approaches may be of a low cost and may be available for many low resource settings. And that's very important that we consider them as potential candidates, but we have to be aware that you see this is the same image taken with different devices, produces different colors, different contrasts, and that's something that we work very heavily in our team. And is that the idea is that we could mix all these different devices, because the example is that we have been working a lot with a model of Samsung, a J8 model, which is not anymore in the market. And now the company, as any cell phone companies, switch every 2 years the model. So if we have a good collection and we want to get an algorithm, how do we guarantee that a new model is going to be useful in our algorithm. So we are working on trying to identify how we can finally have a combined single algorithm that could be portable to different settings from those that we based our algorithm. So further, we need to evaluate our images in relation to potential confounders or effect modifiers. And among many, the most important probably are ectopion or vaginitis that may confuse the images with lesion. HIV is very important. We see many patients with HIV that they have very large images. Sometimes these images are based or produced by an HPV that it's not an oncogenic type, but they are very evident, and we need to really work on that. As well, in sub-Saharan Africa, we have a problem that is schistosomiasis that affects the cervical mucosa, and sometimes these women may go to surgery because they are confused by the diagnosis confused by a cervical cancer, and what they have is parasitosis. And this is a critical problem. We are working as well how we identify and maybe how to use these images to identify that there is a parasite infection there. Additionally, we have to consider color, as I mentioned before, and contrast. And we want to evaluate the impact of green filters, for example, or iodine tinction that may help to identify the contrast in the image, and still working on this approach. So one data that is important is how, if we want to evaluate treatment, how visible is the junction? How in an image we are seeing the transformation zone where there will more than 90% of the cancers or the high-grade lesions will originate in that region. And the work from Nigeria that had been done with Kanan Desai and Dr. Ajani Fusion from Nigeria, they show I think it's a very interesting information that you can see in this graph in the gray color are those images in which there was not a visible junction. So if we don't see the junction, we cannot evaluate treatment, because this means that maybe there is a lesion inside the canal. So we know that this impacts very much women at the perimenopausal or postmenopausal ages, but as well we have to be careful that in young women we can see as well this problem, and we have to handle that. So the potential algorithms we are working now is trying to provide a three-leg approach. One is when we take an image, have an algorithm that will ask, is this image of good quality? If it's not good quality, just get another one, and we don't proceed. Once it's considered of a good quality, then we can have a score, an evaluation of that image in terms of disease or not disease. And finally, and most important, can we provide an assessment of the scamocolumnar junction visibility, and therefore it will be useful to know whether this woman can be treated with an ablation at that moment where we are seeing this woman, or if we don't see the junction, we have to transfer this woman for a surgical procedure. We had, as proof of concept, the group of Mark Shipman published in 2019 the data from Guanacaste based on cervigrams with, as I mentioned, good quality images. And the evaluation of ABE was superior to HPV test screening, or clearly outstanding from cytology or just the looking of the image. The issue here is that all the data set was matched to that data set. So the evaluation of the algorithm was focusing on that data set, and it's what we call it an overfitted approach. And we need now to use all this knowledge to, as I mentioned before, to transfer it to other devices and to other settings. And now we have to work on how this information here can be transferred to other devices. So finally, apart from having this first approach, treat and not treat, we do believe that, and most particularly in this COVID period, we need to approach an HPV testing using self-sampling, and that the combination of additional information from HPV that could be provide a distinction, a discrimination of specific HPV types, together with the evaluation of the image, could provide 17 risk stratum that could, obviously the doctor or the provider should not have to go through this 17 risk stratum, but there could be an application that would result on telling and advising the provider what to do with these women. So certainly there will be a lot of data, we hope, in the coming months. But just I want to call the attention that before an AI-based test is approved for clinical use, we have to fulfill the requirements as any other diagnostic test, have validation of our data, and try to make sure and guarantee that there is reproducibility. That's clearly, we have to show that we improve with AI and with HPV, that we are improving the standard of care. So it's important to monitor and document what we are doing. And we have to really guarantee that we perform stratified analysis by effect modifiers to understand the extension of how generalizable is our algorithm. And with this, I finish with an image that's produced by this NVIDIA conference going on these days, and that's they produce art sculptures based on the dynamics of the brain neurons, and that's a beautiful picture that I find very interesting. Thank you very much for your attention.